Welcome everybody. Welcome to what is now the 6th OMOP Special Interest Group. Thank you very much for making the time in your week to join us. My name is Jeff Hall. I'm a medical oncologist at the Leeds Cancer Centre, but work with HDI UK as their Chief Clinical Data Officer, and have been working with a number of people within HDI UK to raise OMOP and an interest to its adoption. And I'm delighted to introduce as a joint chair, Danny Alhambra, who I saw a few minutes ago, but has now disappeared from my screen. Danny, are you there? And
I am here.
Fabulous,
Jeff.
Fabulous. Danny is here as the lead of an OMOP network, which I'll ask him to say a few words about, and also the OHDSI UK node lead. So Alex has kindly put some housekeeping issues in the chat. And in general, I'm not going to go through all of those, but in brief, please keep yourself muted unless you've got specific questions that you wish to raise. And the data standards team members will just keep an eye on that and make sure that people have the opportunities to introduce themselves. Danny, did you want to just say a few words of introduction?
Yeah, no, just to say welcome everyone. We've got a very packed agenda, which is very exciting always. We're going to start with Alex telling us a little bit about where we are with OHDSI UK. We'll then hear on the HERON UK network, the OMOP Real World Evidence Network. Hopefully Ed is with us or joining us very soon. And then we will talk about maternity and social care data in OMOP. And we have Sinead, Professor Sinead Brophy, who I can see already. Welcome, Sinead. And then we'll hear from the OHDSI vocabulary team. We have the luxury of having an Austropolet with us today. And then the colleagues from SciForce are going to talk to us also about the NHS dm+d vocabularies, which we have a lot to report on. And then hopefully at the end, we'll have some time for an open discussion and for an AOB. As Uaye put in the chat already, if you have any questions, please write them in the chat and we will handle them later.
Brilliant, thanks, Danny. So, Alex, are you willing to kick us off as we get very close to 5 past? I think we've got 77 people now, so 77 people have clearly turned up for your update on OHDSI UK.
Brilliant, thanks very much, Jeff. Hope you can all now see my slides.
Yep, they're fine. Thank you.
Brilliant. So it's just to give you an update on the plans for the OHDSI UK meeting. I'm sure many of you were at last year's meeting, so I will put all the links. There's a number of links. I'll put them all in the chat, or there's QR codes on the screen if you want them, as I hope some of you will. So as a reminder, this is the meeting is co-organised by OHDSI UK and HDI UK. And it's all aspects of the OMOP ecosystem in the UK. So people who do the data mapping to OMOP, people who do the analytics, people who apply it to clinical research, or indeed actually in clinical use. And the meeting will be on Friday, the 26th of September in the Wellcome Trust building. I'm sure, as I say, many of you were there last year. The space worked really well. Everything essentially was co-located with the auditorium at one end, the posters, and everything all in one space. So lots of interaction and networking going on. So we'll have a program of invited presentations. We'll have posters, software demos. We'll have lightning talks selected from the abstracts. We'll also, this year, we're planning to have exhibitors and sponsors at the meeting, which we haven't had before. And we'll broadly organise the meeting into 2 strands: clinical applications and open source software, but not in parallel. That would be sequential. So if you want to know more about the meeting, that's the link and the QR code for the webpage. Just to say, registration is now open. It closes on the 12th of September, which I know seems a long time off, but last year we sold out quite early on, and we've already sold a good chunk of the tickets already. So I encourage you to register early, but also if you do register and you can't attend, please do unregister so that there's space available for everybody. The call for abstracts is also open. The deadline is the 9th of May, so this Friday. So I really encourage you to submit your abstracts. There's a template available, and then you just upload them at that link there on your screen. We are also looking for people to join the review panel to review the abstracts. So if you're attending, or even if you're submitting an abstract, maybe especially if you're submitting an abstract, please do volunteer and sign up to the review panel. We want to have a review panel that represents the whole OMOP community and expertise, again, all the way across the spectrum. So please do consider signing up. And I mentioned sponsorship. We're looking to have a small number of sponsors this year. They will be able to exhibit at the meeting and, have the typical sort of sponsor advantages of logos and information in people's welcome packs. So again, there's a link for those that are interested and would like more details. And finally, just to summarise, reminder of the date, 26th of September. Abstract deadline is this Friday. There's a link there for more details. Feel free to ask any questions in the chat, and I will share the links. So thank you very much, everybody.
Excellent, Alex. Thank you very much for that update. I think the message I've taken away from that is getting quick, because it was a very busy meeting last year, and I'm slightly intimidated that people have already signed up. So I'm hoping I've already been signed up for that. Excellent. Danny, can I hand over to you to take us through today's three speakers? And over to you.
Absolutely. Thank you so much. Okay, so Ed, I don't see you yet. Let me see if Ed is around already. He's sharing slides, so hopefully he's around. So we're going to start with Ed Ban, who is a senior researcher at Oxford, who has been one of the great minds behind the HERON UK network. HERON UK, as you will hear, is an investment from HDI UK to set up and pilot test a network for federated analytics of real-world data across the UK. And Ed is going to give you an update on where we are and also share some learnings. After that, we have Professor Sinead Brophy, who's going to talk about maternity and social care data in OMOP based on some work she's done in Wales. And then we will hear, as I promised, from Anna Ostrokolets, Polina Talapova, and Dennis Kaduk on the OHDSI vocabularies and the NSS dm+d, which, as you may know already, has not been maintained for a little bit and needs a push. And we hopefully will hear good news on that end. With that, Ed, if you're ready, I think even if it's 5 minutes early, I would probably start.
Sure. Thanks, Danny. Hopefully you can see my slides in presentation mode.
Very well.
Okay, so yes, thank you. I'm back. I think I presented at one of these a while ago. So yes, here to talk about HERON UK, the OMOP network we've been working on as a coordinating centre here in Oxford. So just a very quick background to what I'll be talking about. This is a project based on a call for funding from HDI UK last year, where this funding was to establish a coordination centre to organise a network of data partners with data mapped to the OMOP Common Data Model. We were fortunate enough to be chosen to lead that coordination centre, and within that piece of work, we have 3 different work packages. One is a work package on establishing the data network. So this is all around onboarding data partners and then making sure they're ready to perform network studies. So in particular, looking at whether the infrastructure is aligned with all the tooling. So can we run the kind of analytics that we want in the different data partners, and also around what data they've mapped to OMOP, the OMOP Common Data Model, to make sure we can reliably answer our research questions. The second work package was then on undertaking some pilot studies. So these were to do impactful research, so answer important research questions, but also to demonstrate the value of the network, as well as learning what gaps we might have, whether it's in the data, in the tooling, in anywhere in the process of trying to generate some evidence from these different data partners with their OMOP Common Data Model data. And then the third work package was around sustainability. So that's been about overseeing this pilot phase for the first year, and then identifying the opportunities to make the this network sustainable beyond that. In terms of timeline, so we started the pilot in June 2024. In October, we selected data partners after having an open call. We then spent some time onboarding data partners. We then initiated 2 studies, one about antibiotic use and another on high-cost medicines. We then had a study-a-thon in person in March, and now we're kind of dealing with the rather large amount of results we managed to generate during that, and write everything up and finalize those 2 studies, which would take us to the end of the pilot phase in June. So just focusing on establishing the network first. So this is what the data partner network looks like. We have CPRD ORM, so very probably familiar to people, but very large source of primary care data, which covers almost 50 million patients. Records are included there. We then have a number of hospital data sets. So we've got Barts Health, Lancashire Teaching Hospitals, University College London Hospitals, Great Ormond Street and Leeds Teaching Hospitals. And then we've got another data partner, the data lock from NHS Lothian from Scotland, with the University of Edinburgh team, adding another 400,000. So accepting that this is an account of unique individuals, but we're talking about number of people included in this network is around 57 million. Although there is overlap, obviously, with CPRD ORM, including the primary care record of some of the same people as the hospital. So we've got 57 million plus patient records, and establishing this network, just to say, has been kind of built on work already done. So very fortunate for us was that these data partners were already mapped to OMOP. So this is thanks to OHDSI and Eden, and they've also been involved in other projects such as Optima and Darwin EU, and we have analytic packages and so on. We can make use of these existing large projects that have meant that within this short amount of time, we've been able to establish this network and start characterizing the data. Looking a bit more in detail about the data we're capturing, we're talking about somewhere around 850 million condition occurrence records, over 1.7 billion drug exposure records, and 1.3 billion procedure occurrence records. And that's actually without having the results of this part from GOSH or DataLock at this point. And we can see, unsurprisingly, most of those records are increasing by age at younger ages, and they're kind of peaking in late middle age in most cases. So yeah, that maybe already underlines the potential of all the many things you might think you could do with the data. And this is where our pilot studies come in terms of trying to demonstrate how we can generate evidence. So this first study has been focused on antibiotics, in particular antibiotics associated with antimicrobial resistance. So these are antibiotics from the WHO watch list. We've looked at, so far we've looked at the top 10 watch list antibiotics we see for each of the data partners. So in this table, we're seeing the top 10. Some are common across all of them. Some are specific to certain types. So for example, we see vancomycin, which is more typically given in hospital. We see that's one of the top 10 for Barts, Great Ormond Street, Lancashire and Leeds. Whereas others, maybe we're seeing more in primary care, such as in CPRD or so we're identifying the use of these antibiotics from the watch list, and then we're characterizing the users of those antibiotics. So for each of those antibiotics from the watch list, we're extracting large amounts of data on those individuals. So at a very high level, summarizing their age and sex. So we can see the median age. Obviously, one that jumps out is Great Ormond Street. Unsurprisingly, given that's a children's hospital, we see the average age is much, much lower than everywhere else. But then we can see the average age of the different across the different data partners, and we can also look at each of the antibiotics from the watch list in turn. And we've also got a breakdown by sex. We can similarly see in vancomycin, this was the one in the hospitals, so we've got smaller cohorts for that, but again, we can see the average age for those cohorts, breakdown in sex. This is just a very small part of all the results we generated for the antibiotic study. We've also generated information on indications of use, so what infections in particular people were seen to have in the window around their initiation to the antibiotic. We've also looked at whether people have had other antibiotics, maybe not just the ones from the watch list, but also from the access list beforehand to kind of get an idea of line of therapy. And we've done large-scale characterization to kind of do a deep dive into all the different characteristics, all the different kind of records we're seeing for these people. But just at a high level, this is showing, I think, that we can reliably identify users of these different antibiotics and start about characterizing their use. And then we've got another pilot study we've been working on, which is on the high-cost medicines. So for this study, we've got lists of what the NHS would consider to be high-cost medicines. And in total, we see 363 of these high-cost medicines across 3 of the data partners we've run this in so far. So we've got a long list of high-cost medicines, and again, we're going to try and identify their use. Some of these, it's tricky because they might be very new drugs, so whether we'll capture everything is tricky. And also, we found that there's multiple different lists of what would be considered high-cost medicines for different NHS trusts and so on. And so we've been working to pull all that together. But for example, we'll see vancomycin, which was in our antibiotic study. We also see in our high-cost medicine study, along with a range of other drugs for different indications. So we've got plenty of drugs for cancer and so on. Again, we're looking at each of these drugs individually, and we can talk about the different ages of the cohorts of people that are getting them, the breakdown in sex. We're also doing quite a bit of work on the indications and so on of the people getting them. At the moment, we're just talking about the use of the high-cost medicines, not so much the cost incurred because of them. That's like a whole other bit of work we're looking into, but it's kind of tricky because obviously, like, different hospitals are paying have different agreements for some of these. But yes, that's in general like how we're looking at high-cost medicines. So I haven't spent too much time on the results because I also wanted to mention lessons learned. So the reason for these pilot studies was not just those results in themselves, which are hopefully interesting. They're also to try and test this network and see what can be done with data map to OMOP. And there's various challenges that many people who've been trying to conduct research might be familiar. And just to mention a few of those that we've also hit along the way. So one is around the use of UK vocabularies. So these are the vocabularies the source vocabularies used by our data partners that we need mappings for to the standard concepts in OMOP. So our data partners have a mix of terminologies, some of which are international, so ICD-10, we've got SNOMED. These are kind of very well established vocabularies in OMOP. They're being very well maintained. Many more people outside of the UK also need to use them, which helps ensure that they're going to continue to be maintained. But then we also have a set of vocabularies that are a little bit specific to our context. So here we've got things like OPCS4, read codes, dm and d. We'll hear more later actually in this meeting about dm and d. But that's really, I think, maybe a core learning from this first year is the need to ensure that these UK specific source vocabularies are being maintained, ideally that they're being maintained by OHDSI, and that's an open source process, so we ourselves can help make sure they're being maintained and identify if they're going to not be any longer. But also that in the case that one of these vocabularies is not being maintained or doesn't exist in the OHDSI vocabularies, that we establish the same custom mappings across the network to use them. Because obviously, like, if all the different data partners in our network came up with a different custom mapping for, say, DMD, it's actually not very helpful for a network study, because we'll have to use custom code for each data partner. Whereas if everyone's able to have the same custom mappings, or ideally wouldn't have any and would just all use the OHDSI vocabularies, we wouldn't have that challenge. So that's really a key part of maintaining this network going forward as well, not just to be able to use it now, but to be able to use it in future years, is making sure the different source vocabularies that are being used are maintained. Another area that may be of interest to people that we've worked on a lot is around observation periods. So we have data partners such as CPRD or where there's a very well-established way to generate the observation period table in OMOP. In terms of when people are in active observation in the data. This observation period table is used in probably almost every research study, I would have thought, because that's the span of time when we consider somebody to be in observation. The thing with hospital data in particular is that there's many different ways with which you could define your observation period, and the year one partners we onboarded in terms of hospitals, I think managed to all have a different way of defining it. So this could vary from going from the minimum event you see for a person to the maximum event. It could go from the minimum date you see for people to the date of extraction. There's also can be persistent windows. So this could say, for example, we see somebody at the point we haven't seen another record from them after 18 months, we'll drop them. We'll consider that end of their observation period to be ended, and then they can always come back in the future. And we can see the massive implications these have. And really that was shown through in the results we were originally getting for the antibiotic study. So you have, for example, Bart's Health, where you had I believe it was a minimum to maximum. By definition, at the end of your follow-up, you're going to be losing lots of people, because say for the last month of data, the only people in the data then will be people that have records in the hospital that month. So not only do you have fewer people, those people will be more likely to be sick. You then have another extreme of probably the GOSH data, where people were being kept in until date of extract. But then you see some interesting results where somebody came to GOSH as a 16-year-old in, say, 2020. In 2024, as a 20-year-old, they're still considered in the database because 4 years have passed and they haven't been thrown out of the data. Whereas Lancashire, which is this IDRIL acronym, was the one where it was using the persistent windows. So yes, we had this heterogeneity in how observation periods were working. One thing we've done is just come to alignment among ourselves across the data partners of how we'll define observation periods for the hospital data sets going forward. But we've also kind of acknowledged that maybe you'd make different decisions depending on the study. So we've developed some code that would allow you to create study-specific observation periods. So, for example, in this figure for Bart's Health, we're now defining the observation period based on that an individual is seen for at least 545 days without a subsequent record or death or date of extract. So then we can apply that same rule across our data partners in a study. This is also hopefully going to be useful for people if there's anyone on the call that's mapping to like the cohort discovery, the kind of mini OMOP CDM, where by default that won't have observation periods. So this package can let you generate some observation periods for your data, depending on whatever rule you want to apply. So that will be hopefully released as an R package relatively soon. We've also seen the need that we need to work out how to represent some of our UK specific data elements, and in particular consistently across our network. So there are probably a few different places you could put them in the OMOP Common Data Model, and there's maybe a few decisions you can make, but we just want to standardize across the network. So, for example, we've got socioeconomic status. This could be measured by IMD quintiles, for example, or IMD deciles, or some other approaches. And we're trying to we've come to an agreement of where we'll put IMD quintiles in our OMOP CDM mappings. There's also ethnicity. This is very, very hard to standardize across the whole of the OMOP CDM community across the world, because there's so many different ways people are coding ethnicity in their source data. But within this UK context, and particularly because we've got kind of similar data partners in terms of NHS, hospitals, and so on, we're trying to adopt a common approach to mapping ethnicity, putting it in the same fields and the same kind of structure. And for this, we're building on some previous research that was done by another member of our team in terms of capturing ethnicity data in a research-ready kind of way. The last set of lessons learned is probably around all the ethics of doing the studies, both getting the approval to do the study, but also getting the approval to extract the results from, for example, a trusted research environment. Just to underline our approach in these network studies we've been doing, we've been kind of following the typical OHDSI approach of doing a network study where there's no need for people across the network to share any patient level data with the coordination center or between sites. So the patient level data stays where it is. Us as a coordination center, we share the analytic code. The data partners get that code, run it in their environment against their patient level data, and the only thing they have to share back is the aggregated results. And that allows for kind of, and also to mention the data partners are kind of the researchers. They're involved throughout the process, both from like the ethical approval, sharing results, interpreting results as well. This allows for ethical approvals to be done using existing processes, which means the data partners can submit the study as kind of a typical study, whatever that means in their environment. But it has meant that each of the data partners themselves are submitting ethical approvals. So that is a bit of it's a burden on the data partner at the moment in that there's not one centralized mechanism for ethical approvals for our studies. More than that, probably the challenges we've had, more than getting protocols approved, has been making sure that everyone's happy to share aggregated results. That's mainly just around how different organizations understand disclosure rules and where the line is drawn. And when people say, oh, we'll apply a minimum cell count of 5, that's easy for me to say, but then making sure that the implication of that aligns exactly with their disclosure rules. So whether it's how that works with study attrition, reporting on maximum ages and so on, is definitely like an area we've come up against in terms of doing the research, and somewhere where we need to find a way that it's very explicit so that programmatically we can apply these rules for all the data partners. Lastly, just on next steps for the network. So we're working on disseminating the findings from the different pilot studies and establishing the network that I mentioned earlier. So we've got OHDSI Europe abstracts, and we've got the deadlines to submit for OHDSI UK and the HDR UK conference upcoming, hoping to write manuscripts on them as well. What's clear is kind of the need for further standardization, coordinating the dm+d update that we'll hear about later, making sure the R package we use for characterized data works, and we continue to expand that. We'll release an R package for generating these observation periods, making sure our approach and software can be used across like the variety of infrastructure people have, so especially trusted research environments with the rules about importing code, exporting results, and then also trying to adopt some external tooling, because I know there's lots of work going on in kind of a very related area. So for example, the Acro tool for output checking, if we can adopt something like that, it would make our lives much easier in terms of getting the results at the end. And it's very clear that we've all agreed this is what the data disclosure rules are within the network, and then this is a tool that will apply those and validate that those have been followed. We're hoping to expand the network, so incorporate additional data partners, especially from trusted research environments and the NHS SDE network, as well as increasing the depth of our onboarded data. For example, improving device data, making sure that's ready for research, demonstrating that it is as well. We're hoping to start doing externally funded studies. So again, demonstrate that the network can be used for a range of purposes, so that it can be used for regulatory research, industry-led studies, and also participate in international network studies, such as those being run within the OHDSI network. And then, lastly, also just make sure that we're aligning with, supporting, and learning from other initiatives. So there's an ever-growing list of acronyms associated with the OMOP CDM acronym. So we've got OHDSI, EDEN, Darwin EU, HDR UK, DARE UK, NHS SDs, and now we've got the Health Data Research Service coming, and making sure that the way we're trying to do research in our network will matches and builds on and learns from all these other initiatives. So plenty of work still to do. Just to finish, thanks to all the HDR UK team supporting the project, the various colleagues here at Oxford who have been doing much of the work, and all the data partners themselves who are kind of fundamental to the whole thing. And with that, I'll finish and say thank you. I'm not sure if we're taking questions now, Danny, or at the end.
We're a bit tight with time, so I'm going to suggest that we postpone the questions for later if you can stick around.
Sure.
And we have some time for discussion later that we could potentially use. Okay, very, very interesting. I hope everybody found that exciting. Next, we're going to go to Sinead Brophy, who's going to talk about maternity and social care data in OMOP. And I think she also has some interesting news to share with us and some interesting stuff. Sinead, whenever you're ready, please go on.
Thank you. Thanks a lot. Let me just, is that sharing properly? Is that okay?
Yes, I see it very well.
Brilliant. Thank you. So I'm just going to talk about MORADA, which is the Mother and Infant Research Electronic Data Analysis. And that's really taking existing birth cohorts, which are born in Bradford, born in Scotland, born in South London, Elixir, born in Wales, and I'm harmonizing them using the OMOP standard structure, as well as Mum Predict, which is using CPRD in England. So trying to harmonise all of those in order to develop a UK birth cohort that would have about 100,000 new babies a year across Wales, England, Scotland. So I'm just going to talk a wee bit about what is Merida, what we've done so far, some funding to work with the Merida data set, what we're doing with health visitor data, and then Steve-O is going to talk a wee bit about experience of OMOPing BadgerNet. So this is us, a picture of us there, and who's in the partnership. So at the minute, Merida is to create a UK data set, which is a core data set. So taking the GP and hospital data in pregnancy and at the birth, and then using that core, which is using the OMOP common data model, and linking that to local data sets. So for example, in Wales, we can link to the census 2011 and 2021. Each of them, each of the cohorts can link to the health visitor data. We're linking to education and of course to primary and secondary care after the birth. As you can see, the majority of the data, so it's like 7 million, it would come from CPRD ORM. So most of the data is in England. So if you want to look at how common something is, you're better off just doing it in CPRD. But if we want to look at local variations and like local policies or things like that, then Merida would be good for that. So what we want to do is really look at natural experiments of what happens in one area of the country and how that compares with maybe different policies in a different area. So to improve our ability to undertake natural experiments using routine data. So each cohort maintains their own data, and so that we can do sort of aiming at a federated analysis, but at the minute just sharing the same script and getting aggregate data and trying to form a sort of dynamic UK-wide birth cohort so that it can be updated every year. You can see here that there is quite a bit of variation. So even if you take just CPRD, in ORM, the preterm rate is about 6%, whereas in gold it's 8.8%. And if you take born in South London, that goes up to 9.6%. And in Wales, it's 7%. So there's a big variation there in being born preterm. And it's not clear because this is the crude data. And this is old data, that this was last year's. We've got larger numbers now, but it's not clear if when we look at this, when it's been harmonized, whether those percentages would change or whether, and this is just something to do with how it's coded in the different data sets, or whether there is that much variation across the country. So like I was saying, we're going to have a core, which is OMOP standardized, and then that will link to things like health visitor data or census or social care data sets. So that means that if something's held in one area, we hope to be able to look at, can you impute and extrapolate? So for example, if we use the census in Wales to work out if somebody is living in poverty, and we say, look, the variables that you find in the core data that would be associated with that, can we then impute that into the other areas of the country, for example? There is some funding to help sort of kickstart research, which is with Merida. So we have 3 lots of 20,000 for people who would like to use a data set, and but that could be to do pilot work for a grant, to do a paper maybe, to develop training models to use it, or to work internationally with other OMOP common data model data sets. So there's going to be a workshop in July the 11th, and that's in partnership with the European Group in International Society for Developmental Origins of Health and Disease. And at that workshop, they're offering a travel grant, and we're offering the 20,000 pots. In the morning, we'd talk a bit about what we've learned using the OMOP in Merida, and then have talks about what's actually needed in terms of the research in maternal health and what's needed in preconception health. In the afternoon, we're aiming to talk about ideas that for analysis. So whether that's something like using the seed corn funding to bring together people for maybe an EU grant kind of idea, or to look at the differences in the preterm rates and why these differences are there, or just looking at projects that need collaborators. So for example, the Preconception Network Group, maybe working with them. So this is face-to-face in Cardiff, but it's also hybrid. So if anybody would be interested in joining, it's also hybrid as well. What we plan to do in our project is we're looking at the difference in rates if you have raw data versus when you use the OMOP data, and does things change? We want to look at proof of concept, or show proof of concept that we can use this for natural experimental methods. So we'll be looking at maternity grant policy in Scotland, which is a bit different than it is in England and Wales, and looking at does that affect the outcomes at the birth for families. We're doing a proof of concept that we can use this as like for cohort analysis. So what we want to do is look at factors in pregnancy which are associated with the health visitor having a concern for the baby. And we want to develop research development groups after the workshop. And we want to do a training model, which maybe hopefully would, of how to use maternal OMOP data, and hopefully put that on horizons with HDR UK. Now, we are also looking at using health visitor data and seeing to the extent to which you can OMOP health visitor data. So that means we're trying to harmonise, well, what is the same in the health visitor data in Wales, England and Scotland, and they are quite different in how they're collected. So what is common across them? The extent to which existing OMOP codes could be used in order to assign those to the health visitor data. We do want to use the structure of OMOP for the health visitor data, but we might need to assign new codes to the data but they would be held within the common data model structure. So that's what we're doing with health visitor data. And I'm now going to hand over to Steve-O to talk about experiences of OMOPing BadgerNet. So I don't know, Steve-O, if you just say next slide, I'll go forward.
Okay, thanks, Sinead. Hi, I'm Steve-O de Barber. I work at KCL and I'm part of the Merida team, and my experience of doing the sort of like IT back-end stuff. Okay, so the Elixir data, the early life course data cross-linkage in research for South London. The data that I access is on a secure data environment at SLAM, South London and Maudsley Hospital. It's data that's been linked together with their clinical data linkage service. So we've got BadgerNet data from Guy's and St Thomas's, King's College Hospital, and the PRU, the Princess Royal University Hospital. What I'm working within the secure data environment are a set of extracted CSV files, currently 25 maternity files, 6 neonatal files, 14 health visitor files, and basically it's an environment using R and Python. May I have the next slide, please, Sinead? Okay, so basically I'm a small cog in the wheel, and really what I need is the expert insight. So you get the bulk extract CSV files, we generate a white rabbit scan report, we've got the schemas of the code books, we've got what Merida would like from their cohort and their data specifications currently based around live birth only, and then we back it up with resources in from Athena, OMOP vocabulary, NHS Snowred browser, basically going out to the web to sort of sense check because I'm always worried that I'm doing things wrong, and it's an important element is the team insight. So it's the expert insight in the whole team that's important to generate the mapping rules, and the mapping rules are used to generate CSV files for CARA OMOP mapping, and I'll explain what CARA OMOP mapping is now very briefly. Sinead, may I have the next slide, please? Okay, so CARA is a website. You probably know more about this than I do. It's hosted by the HERON UK, and as part of the Merida project, we are lucky to be supported by CARA, and so we reshape our CSV files for mapping into the Carrot tool, and it involves one element is a white rabbit scan report, which we strip out frequencies, and another is a data dictionary, which basically says for some rows and some columns we are using SNOMED or ICD-10, but it gives a general overview of some of the data in there. We upload the data into the site, and then hopefully it does recommended mapping. So I'm not sure if you can see this, but this is methods of delivering it, and it says for these words we recommend you map this, and occasionally you would manually change it. So the greens recommended, the blues what we decided amongst the team to manually change it, and then once you've gone through all your CSV files, we've got about 20 in our set of CSV files we load into CARA. Then it generates a CSV file of mapping rules, and also a JSON file for the Carrot Mapper, which is a tool you use locally within the secure data file environment. And then we slightly modify the automatically generated JSON file so that we can handle some long data. Next slide, please, Sinead. And then this is basically the data flow once it comes out of Carrot. So you've got your CSV files for Carrot mapping. Carrot has a pseudonymizer file. I mean, our data's already pseudonymized, but it ain't gonna hurt, so it's pseudonymized again. With the Carrot pseudonymizer file, you've got your ETL tools that use the JSON file and a config file. So you pump it all together in a nice little command line. You hit the command line, you go away, have a shower, have a cup of tea. A few hours later, it's done for you. And then you get, with this tool, you get a shed load. Literally each concept has its own tab separated file. So we've got over 1,200, and that, thanks to name convention, that all just shrinks down to 6 CSV files with the OMOP stuff, or is it 2, 4, 6, 8, 7? So 7, and including the fact relationship, which we generate afterwards. That is actually something that needs to be developed even more, because I think one of the keys is actually all the interrelationship of the pregnancy data that needs to be developed. But we can generate the CSV files, and then once that's done, we can use the R synth-pop script, and then we can generate synthetic data to share with the rest of the Merida team so they can develop their analytic code. And that's about it. Hopefully that made sense.
Thank you so much, Bob. That was fantastic. Sinead, did you have any other content you wanted to cover?
No, that's it from me. Thank you. I can see there's some questions in the chat.
There's tons of questions in the chat that maybe you can try and take in writing. I can see there's one hand up, and we're still 4 minutes behind time, so we can probably afford it. Tom?
Just super quickly, if anyone wants to learn any more about Carrot, feel free to reach out to me. I've put the link in the chat.
Thank you. Sinead, can I ask a cheeky chair question?
Yeah.
So I have a PhD student who is doing quite a bit of work on vaccine and medicine safety in pregnancy. And I also saw some other colleagues were asking questions about paternal linkage. So of course, this kind of linkage, mom or dad's baby, are fundamental for, you know, the monitoring of drug and vaccine safety, right, amongst other things. And I was wondering, will you have that data maps, like, you know, the drug exposure, drug era, vaccines, all of that in your initiative, in your cohorts?
Yeah, we well, I mean, we've been looking at vaccines, and so yes, obviously we'd have to sort of design it according to and make sure that we've mapped what we need. It's all in there. It's whether we've mapped it, yeah. And so yeah, it's feasible, and definitely we're interested in working on vaccines too. So yes, it is feasible. It's and doable, very much.
Fantastic. I might bother you offline then to talk about business. Thank you so much. That was fascinating. Any other quick questions? Otherwise, if you agree, Geoff, we can jump ahead to the next
in terms of
speakers.
paternal data, there's a question there about linking to the dad's data. Yeah. So that is to an extent feasible, in terms of, in many places you can link to adults in the household, so you can look at household members, yeah, and you can put in rules like that the person needed to have been in the household like 9 months before the baby was born, and be an adult male in order to try and figure out who the dad is, yeah, but we wouldn't know for sure a biological dad. Yeah, we would know who a child grows up with, but not necessarily that that's their biological dad. So we can do those type of things.
Yep. Fantastic. Thank you so much. Okay, I think that's a very, very promising development, and indeed, potentially, you know, if you succeed, which I hope you will, proof of the, you know, power of making data interoperable and truly, you know, have similar data to run analytics across. Thank you so much, Sinead and Steve-O. I'm going to ask Anna to jump in. We're going to be talking now about OHDSI vocabularies and the NHS dm+d specifically, which is a potentially more technical and a very different topic, but a very important one for everyone in this call, hopefully. Anna, if you're ready, please go ahead. Thank you so much for being with us. I appreciate that you're probably a little bit early in the morning where you're based.
Absolutely. Thanks so much, Davey, for inviting. So my name is Anna Ostropoulos, and I'm the vocabulary work group lead. And one of the objectives of the work group is to increase transparency in how vocabularies operate and in their content. So this is why I will use the next 10 minutes to go into more technical and deep details about what happens under the hood of the OHDSI vocabularies. And of course, because we have so many different people on the call with the different levels of expertise, let's start with the very basic. So the reason why OHDSI vocabularies even exist is that they are the cornerstone of the OMOP common data model, in the way that OMOP CDM is really the only CDM that not only does structural standardization, where you have the same set of tables, but it also performs semantic harmonization, meaning that there is a unified semantic level of ontologies that make all of the OMOP CDM data sources speak the same language. And this is something that is unique to OHDSI and to OMOP CDM, because none of the other common data models really do this harmonization. And when I say the common language, what I actually mean is that, for example, if you were to take drugs, as you might know, the drugs are coded using all sorts of source terminologies in different countries. Here in the US, we use NDC. In France, they use BDPM. In UK, they use dm+d to code drugs. And for us to be able to do network studies, to collaborate, we want all of that to be linked to a common reference standard. So in a nutshell, vocabularies are the combination of the source vocabularies where we try to preserve their structure, but also the additional layer of crosswalks among those source vocabularies and the reference standard. In case of drugs, we chose RX norm, and then additional reference standards were added down the line, such as RX norm extension or CBX. So that crosswalks is something that we create in-house using a variety of approaches. And these crosswalks is sort of what distinguishes us from the other common data models. And on top of that, in addition to speaking the same language of the reference standard, we also have hierarchies. So here in orange, you also have the link subsumes from ATC to RX norm highlighted, because creation of the hierarchies is yet another big piece of vocabulary maintenance, because we create those hierarchies in between vocabularies ourselves while preserving source hierarchies if they exist. For example, RX norm has a very, very nice structure. In fact, if you were to learn about RX norm structure, that would help you in your research a lot. And the last time I gave just the tutorial on how to use RX norm, I think it took something around 40 minutes. So there is a lot to learn in terms of what we do and how to use it. But the bottom line here is that there are two pieces that we do in-house as opposed to just importing from the external sources. And this is the crosswalks from the source vocabularies to the standards and the hierarchies. And what I'm going to do now is I'm going to take an example of a UK vocabulary, dm+d, that is used to code drugs, and I'll walk through some of the steps of how we process the vocabulary and what we do with it in order for you to go into Athena and download the vocabulary and then use it in your ETLs and research. The very first step is to import sources. Vocabularies, at the end of the day, a big part of it is being a collection of all of the data source, of all of the vocabulary sources. So what we do when we import it, on the GitHub for each vocabulary, we have the README that describes the source where we downloaded the data from and how we download it and process it. So here, for example, you have a screenshot of dm+d and how we go onto the NIH website, download the root files, and then process it. That is done automatically through the set of Python scripts, but we also get source vocabularies from all sorts of data partners. For example, the last one, GMDC, is coming from people who work with Japanese data, and they send us the files. But the majority of the files that we receive automatically, and we resolve the differences in between versions automatically as well. Now, the next part is actually harmonization and processing of these sources. And as I said already, two big parts of it is creating the crosswalks, resolving any inconsistencies in between releases, and creating the hierarchies. And in general, this is what we call a load stage. So again, on our GitHub, here we have a snapshot. Actually, I probably should take a pause and say that our GitHub vocabulary is where you can find all of the code, and this is where you can find lots of documentation on our wiki pages in GitHub. So for each vocabulary on the GitHub, we have load stage that essentially is a set of SQL code most of the time that describes how we process the source. And while there is much more to it, a very high level overview of this process is that when we perform this harmonization from the source, we take the sources that have various different structures. It can be CSV files, it can be other forms, like for example here, you can see the example of dm+d and XML files that are on their official website. And at the bottom, you have the black box that is a snapshot of some of the drugs stored in that XML format as Trude and dm+d have them. So the very first step for us is to standardize this data structure. And this is where we convert these these drugs in this data structure into our common structure in the vocabularies. And you can think of the parallel with the OMOP CDM being the common reference structure for data, for patient data. This is the common structure for vocabularies. And these staging tables essentially allow us to do processing that is vocabulary agnostic. And this is where we can come up with more advanced quality assurance. This is where we can come up with innovation, because regardless of what we take, we all convert it to the same vocabulary agnostic structure. And actually the structure mirrors the tables that most of you are probably very familiar with, which are concept and concept relationship and concept relationship. And that, of course, was done on purpose. So whenever we import tables and convert them into this staging structure, we fill the concept codes, concept names, domains, vocabularies. The fact that it mirrors the structure of the final tables lets us seamlessly transition from this staging tables to the final tables that you can see in Athena. And there are more steps to it when it comes to processing of different vocabularies, when it comes to integrating everything into a single release, when it comes to transforming concept stage into concept and concept relationship stage into concept relationship. But instead of going into too much detail on that, I would just encourage you to reach out to us or to check out documentation if ontology development is something that interests you, or you just want to learn more about what kind of quality assurance we have or the processes that we have. So instead of going into details, I wanted to also draw another parallel. And the parallel is between these vocabulary agnostic tables and the community contribution. So the community contribution is something, is an initiative that we set in place, I think 2 years ago, where we wanted to democratize the development of vocabularies a little bit more. So we said that there are several use cases where we can take users' input, and by users' input, I mean users who do not have a very deep expertise in the vocabularies, just users, maybe IT people, maybe researchers, take those use cases and come up with a simple pipeline for them to contribute their content. And a good example of such content can be a new non-standard vocabulary. For example, we have a lot of interest in surveys and scales, and we see a lot of contributors wanting to contribute non-standard vocabularies for surveys. So for that, the way the pipeline works is that you open the issue on vocabulary GitHub and you fill templates. And those templates, of course, there is more documentation in the wiki, but these templates mirror the structure of our staging tables closely. And what it allows us is that whenever you fill the template, we take it in, we run the same quality assurance that we do internally, and we put it into the release. So the sort of mirroring of the structure and the common structure allows us to process user content and community content more efficiently, faster, and of course, hopefully less error prone. Now, I also want to say a couple of words about harmonization of drugs, which is slightly different from harmonization of other domains, such as condition and procedure. And as we are shifting gears toward drugs, the reason why we have separate procedures for drugs is because the structure of drugs is very clean. So what you can see here on the screen in the center is the breakdown of drugs with different granularity. For example, we can start with an ingredient, samantidine. If we add drug strength, it becomes a component. If we have drug strength and dose form, it becomes a clinical drug, and so on and so forth. So even visually, this figure shows us that the drugs can be broken down into attributes, and they also have a very nice clean structure in terms of their hierarchy. And this is one of the reasons why we came up with a a systematic process for harmonizing drugs. And this is where, for example, RX norm extension is coming from, which is the extension of the RX norm, a reference standard in the US, to cover international drugs. And that process, which, if you're interested in it, I would be happy to provide more details and more links. In a nutshell, breaks down drugs into their attributes, maps the attributes to the RX norm attributes, and then assembles new codes, assembles hierarchy, and assembles mappings. And the reason why I mention it, there are two reasons why I explicitly mention it as a separate process here, is A, because we will talk about dm+d and our wonderful collaborators who will be refreshing it this cycle. But also I wanted to point it out so that if there is an interest in the group to add other drug vocabularies, which we see now a lot in Europe, because it's in such a nice structure, we actually have a full separate pipeline for you to contribute your drug vocabularies, and we're able to leverage the machinery that we created, and we're able to leverage the RX norm extension, which is our in-house vocabulary for international drugs. And before I transition to Polina and Dennis, who are going to talk more about dm+d, I wanted to show you the last final slide, which I think is probably the most lauded, which outlines the steps that one needs to take if they were to add a drug vocabulary or refresh a drug vocabulary. And this, I think, motivates the work that Polina will be talking and Dennis will be talking about, because as you can see, there are multiple steps if you were to add a drug vocabulary or refresh it. You need to prepare the environment schema with all of the functions that we have on the GitHub. And while the functions are all open source, it does require some technical expertise to set up the environment. As I already said, because of the nice structure of drugs, we can leverage the systematic process, which requires step 2, parsing your source drugs into attributes, such as dose forms and ingredients. Then, instead of mapping all of the drugs, you just map the attributes to the standard concepts in RX norm. So, for example, if you have ingredients in dm+d, you would map them to the standard terms in RX norm. That altogether makes the content for what we call the input tables, which also have a very standard structure. You perform quality assurance, you run the machinery that creates new terms, creates hierarchies, and creates crosswalks. You again do quality assurance, and then you do the final step that integrates everything together, assigns concept IDs, and forms the hierarchy. And you can see here that quality assurance is mentioned at least in two times, but of course, when it comes to the actual process of harmonizing drugs, but also harmonizing other vocabularies, quality assurance is a big part of it. And it happens to be a very iterative process where when somebody builds something, they find errors and they have to constantly go back and forth to fix them. So over the years, we kind of spend a lot of time on enhancing quality assurance and quality control, but still it remains a very much iterative process. And I think this is true for other domains too. If somebody wants to contribute their content, their new vocabularies, I think what they need to be prepared to is that there will be a lot of back and forth in terms of the quality assurance. And with that, I'm going to stop and I'm going to pass it over Denise and Polina. I will also post the links to the documentation, and I would encourage everybody to come to the work group and also ask your questions as well in the chat.
Thank you, Anna. Polina and Dennis, are you ready with your presentation or your talk?
Yep. Thank you. Let me share my screen. I hope you can see it and hear me well.
Yeah, very good.
Yeah, so hello, apologies. I'm Dennis, tech lead from Cyflorus. It's a pleasure for us to be here today to share the story of us and how we streamline terminology integration in healthcare using mapping of DMD into the OMOP standardized vocabularies. Here is a small agenda what we talk about for today, and let me tell about the imagined world where clinical data lives scattered across numerous systems and formats, where every new code set or local term demands months of negotiations and manual updates to a central repo. That's the reality many organizations face with, and it's precisely why Cypher's exist. And back in 2015, was assembled a multidisciplinary team of over 75 experts, clinicians, bioinformatics, software engineers, and scientists, holding bachelor's degrees, master's degrees, philosophy doctors, medical doctors, with a mission to make medical data true interoperable. Good. Yeah. Since then, we've completed more than 100 projects for over 70 clients and earnings the highest levels of client satisfaction. Our expertise spans ontology development, observational research, support, data harmonization and mapping, as well as ETL pipeline construction, AI and machine learning model development, and fully integrated software solutions, including the deployment of large language models for healthcare scenarios. But the vocabulary mapping project is not just about the writing code. It's about the community as well. So the shift from a centralized approach where one team handled all updates to a decentralized workflow will significantly increase efficiency of vocabularies development. A team with the clinicians who map terms, for example, some local terms to SNOMED, or engineers who can develop a script to map a drug, as mentioned Anna previously, using machinery, submit all pull requests to vocabulary team. Those contributions undergo review and discussion before merging into the main vocabulary repo, and this democratized process accelerates updates without overburdening a single team. On the technical side, for example, we maintain a production mirror of the OMOP vocabulary database, leverage open source tools and GitHub workflows to track changes, and collaborate directly with OMOP vocabulary team, filling issues, triaging requests, and ensuring that mappings reflect the correct clinical content. And we, as mentioned, we maintain a dedicated channel with the vocabulary team. Each issue submission undergoes preliminary review. Detailed comment threads captures clinical, rational, and mapping logic, ensuring updates are both thematically accurate and technically robust. This tight loop of feedback keeps vocabularies precise and reliable. Of course, there are challenges as we faced with dm+d. In the DMD conversion, the core loading script spanned almost 6,000 lines of complex SQL queries. Even the indexed tables execution times are prohibitively long. Some reference tables are deprecated or missing in the repo, so causing the errors or unexpected failures. And buried within the code were undocumented some legacy functions, forcing us to reverse engineering the logic and rewrite them entirely to align the current OMOP vocabulary standards. And in the last words, let me introduce you Jackaloop, the machine learning powered platform for medical data mapping and vocabulary management. The Jackaloop can post-coordinate even the most intricate clinical concepts and dramatically simplify ETL workflows and maintain flexibility through a blend of automated processing and manual validation. Oops. With Jackaloop, you can align the source data with OMOP CDM rapidly and reliably, extend curate vocabularies, adding new concepts and running outdated ones, identify and map previously unmapped elements, boosting data completeness and accuracy, and automate mapping with ETL pipelines slashing manual effort. And why you choose us? Because we can fuse deep clinical insight with cutting-edge technologies. We've contributed to multiple core OMOP vocabularies, and we are certified EDEN partners and active members of OHDSI community from day one. And our work spans pharma research institutions and startups alike, keeping us at the forefront of emerging trends and best practices. And in closing, mapping of DMD into OMOP CDM isn't just a technical milestone. It's a step forward to more accurate, integrated, and efficient clinical data analysis through community-driven process and Sci-Force proven expertise. We are turning that vision into reality. Thank you.
Thank you, Dennis. Is Paulina gonna show any slides, or I saw she's around, but otherwise I think we can take questions if there's any questions from anyone. The vocabularies more widely about the update of the M&D that we're planning. No questions on the vocabularies, Anna.
It is a very niche topic up until you have problems, and then all of a sudden
Exactly.
people have questions.
It's mainstream. All right. I think Dan Dittman from CPID, his hand is up. Dan, come in, please.
Yeah. Thanks. It's fantastic to see this this initiative as a result of some of the problems we've had. I just ask, I don't know if I missed this in terms of the timing and the expected sort of timelines for delivering the next sort of mapping of DM&D.
So we have that's a wonderful question, and I assume that everybody knows it because I talk about it so much, but it is a very good point. So in general, we have biannual releases. So the next release will be August, and then after that February. And the team is working really, really intensely to meet our deadlines, our community deadlines for the August release. So the expectation right now is that the updated dm+d will be available in the August release, which is going to happen at the end of August. And then I think September 1st, you'll be able to download the vocabulary from Athena and then go check it out.
I think that made Dan's day and mine. Any other questions? Geoff, we had allocated 10 minutes for an open discussion on suggestions for future OMOP SIG meeting topics. I guess we didn't give anyone the opportunity to ask questions to Ed or Sinead, and I think they're still both around. So if there's any questions for any of the speakers, I would say please raise your hand. Otherwise, we'll just go ahead with the next topic.
Yeah, so there's been some questions and answers in the chat, and I'd encourage people to look at the chat. One of the incredibly useful things about this community is the general attitude towards sort of open team science. So the links that everybody has put, Anna, in your slides, and Ed sort of referring to GitHub repositories, for those of us who need a little bit more time to sort of read things through to understand them, it's incredibly helpful. So I would encourage everybody to share the slides from today and share as many links into more detailed repositories that people have. But are there other more specific questions for individual speakers today? I can't see anybody.
I see David's hand is up, Geoff.
Oh, David, there we go. Sorry, David.
Yeah, no, that's all right. Thank you. A bit of a question, I guess, probably across all speakers, and perhaps leads a little bit into the next discussion. But I guess there is so much happening, isn't there? There is so much opportunity to share knowledge at sort of all stages of its development. I guess it links a bit to the question I put to Ed, but I think more generally, how do we make sure that people can sort of find out about this, input to it, adopt it, or whatever it is along these things, and sort of share that communications in the most, I suppose, efficient and effective way. It feels like we're sort of scratching the surface of this really, and there's only going to be sort of more activity, but also then as a result more opportunities for learning, but equally relearning or recreating the wheel.
Who was that question for, David? Is that an open question to anyone who wants to take it?
I guess it is really. I mean, it feels like obviously, from Anna's point of view, she's set out very clearly. There is clearly a well managed process there. I guess we've got to sort of dock into that, and I guess that was sort of laid behind the sort of the Odyssey community fora and things like that. What can we do? Is there anything we need to do specifically at a UK level or more that we could be doing? And I guess that's probably open to any of the presenters really.
Yeah, maybe I can start with to say, I guess one thing is understanding which problems are like your unique problem, a UK specific problem, or like a global, anybody mapping to Odyssey problem, which is actually quite tricky sometimes, but there are sometimes just unique problems with your source data that you can put on the Odyssey forum, but there's not much people are going to be able to help with. And it's kind of hard work to fix it yourself sometimes. There are then like the UK specific issues. And I guess one thing is just, I think Odyssey UK is a good way to collect those. And then if they go into Odyssey in general, so like the dm+d is a very good example where the most people affected are the people on this call. If it was, say, an issue with the SNOMED vocabulary, it would be a more like global initiative. But then that can all feed back, I guess, into the main Odyssey vocabulary ecosystem, which is why it's so useful for Anna. So I think with Odyssey UK, maybe in some ways we're an intermediary sometimes, trying to collect like the most important problems people are facing and pass them up the chain. But yeah, maybe that's the way I would kind of see it at the moment.
And then you would also need to, sorry, go ahead, Geoff.
Ed, I think that's actually a really good response, because speaking as somebody who sort of at one level assumes that if I can't work out how to do something, it's my ignorance that must be stopping me. I think it has been incredibly useful to have this group of people with a shared interest, but then actually having the Odyssey UK leadership provided by yourself and Danny is incredibly helpful. But very occasionally I have got to issues that people go, oh, that's something the whole international community is struggling with. And actually that is the moment to engage the Odyssey groups globally. But I'm really glad I haven't asked all of my very trivial questions to the Odyssey global community, because they'd have got very bored with me.
This is definitely not the mindset. As a person who spends a big portion of her time answering questions on the forums do exist to answer silly questions. And yeah, people will say there are no silly questions. There are silly questions, but we're happy to answer them. And I actually wanted to slightly change the perspective here in the way that learning about the processes and learning about what's in your data is very useful. And I found the most efficient way to do that is actually to try doing studies, try creating cohorts, of course, if your data hasn't been ETL'd yet, that's a separate question. But if you have your data in place, try engaging in the common activities. So if there is one thing that I would encourage you to do is to actually go ahead and try doing something yourself. And right now in the community, there are 15 network studies, bigger studies that are happening across the whole community globally. And there are many different topics there that you can engage with, depending on the expertise, from data quality to creating phenotypes to learning more about any of those aspects to actually actively engaging in the studies. And while everybody is at the very different stage of familiarity and like familiarity with the processes, I found that the time I learned the best is when I engage. So that would be my 2 cents. And I've heard a wonderful presentation about the maternal data. Well, there is a maternal work group who are working on creating algorithms to identify pregnancy periods, for example. This is something you don't know until you engage. And then when you engage, you learn so much more by just being in the community and trying it out for yourself. So that kind of provides a slightly different perspective on not waiting for the smart questions, but actually going in with the silly questions and also testing out and trying out things for yourself.
Anna, can I ask, related, I guess, again with this kind of idea of national and regional nodes, which is kind of relatively new still in the OHDSI community, right? I think there are going to be situations like the dm+d vocabulary is a good example of it, where we could potentially leverage national context and know when things are going to be updated with those vocabularies. And I know that some of the colleagues in the call know or could get hold of the people who are in charge of the NHS dm+d. I guess that's useful intelligence for you guys in right. So that's something we should probably get better at collating and disseminating and channeling, because there will be these vocabularies that some people know are going to be updated potentially well before that happens.
Yeah, yes, exactly. I would not think, like as for example said, the problems of local community versus global. I would specifically not phrase it in this way for the reason because the community consists of individuals, organizations, and nodes. So I, for example, when in our vocabulary work, I make no distinction between local vocabularies or global vocabularies, so to speak. We have a distinction between reference, standard, and source vocabularies, but dm+d is no different from BDPM or other ontologies. So from that perspective, we do have a gap of not covering all of the source terminologies, and that gap exists in Europe a lot, and we're actively trying with Peter, with Danny, with others, we're actively trying to cover this gap. And this is why I brought up the notion of the community contribution, is that if you, in your data, see that something is not mapped and there is a vocabulary that you use that you would like to add, the task is actually to reach out and for us to figure out how to make it happen. And then on the side of the control terminologies like dm+d, if Danny, you could connect us, that would be of tremendous help. Absolutely.
Right, we have 40 seconds before we need to close.
I'm sorry, I took too much time.
No. This has been a fabulous meeting. I hope everybody will agree. I learned a lot. Geoff, do you have any final AOBs or any final words?
I think we should draw to a close. I'm acutely aware that the number of people on the call is beginning to drop because those will be people moving to 2:30 meetings. So thank you everybody for joining. We had